talking about bupropion. While I was writing my notes for this, I realized that I've always thought it was buproprion, but apparently there's no R. Bupropion sounds wrong to me, but I guess it's bupropion. Yeah. I make mistakes. I also, in my other video, I guess I was pronouncing it escitalopram, and it's supposed to be escitalopram. Like it's a soft C, or, yeah. And I messed up. So yeah, I guess that means that's a career long of pronouncing the most basic medications I use incorrectly. One thing I think is funny is when psychiatrists or therapists make mistakes and like make pretend it was for therapeutic reasons. So for that, I was just modeling how to gracefully make mistakes. You're welcome. But yeah, let's get to it. So we're talking about Bupropion and Wellbutrin. So let's get started with the FDA indications. And the FDA indications, if it has an FDA indication, doesn't necessarily mean it's has the most data for what the indication's for. And on the flip side, if it doesn't have an FDA indication, it doesn't mean that it's not useful for that diagnosis. There's a lot of like politics, big pharma marketing stuff involved with what gets an FDA indication, but it is helpful as a starting point to learn what a medication is useful for. So the FDA indications for bupropion, the first one is major depression, and I'll put up here which formulation has the FDA approval. So yeah, it's major depression is the first one. Then seasonal affective disorder. I'm pretty sure it's the only medication that has an FDA approval for seasonal affective disorder. Then smoking cessation, and for that it's marketed as Zyban. Then there's two that when it's put in combination with another drug, it has an FDA indication. So the first is Contrave. I don't know if I'm pronouncing that right. And that's when it's combined with naltrexone, and that's used for weight management. And then the other one is Auvelity, and that's when you combine bupropion and dextromethorphan. And that indication is for major depression, and it's usually considered a little bit more rapid acting than the other antidepressants. And then it's used off-label for ADHD. It's not nearly as effective as the stimulants, and I'll talk a little bit more about that later. It's also used for sexual dysfunction. Again, not amazing, but pretty good, and I'll talk about that in more detail later. And then also bipolar depression. So I think it might be helpful to start with a quick summary of Wellbutrin. So it's mostly just considered an antidepressant that helps a little bit with ADHD. And a lot of people think of it as like the sleek, sexy, skinny cousin to the SSRIs. And that's because it doesn't have the side effects that a lot of people are worried about with SSRIs, like the weight gain or the sexual side effects. So one thing that can be a little confusing is there's a ton of different formulations of bupropion. So there's Wellbutrin, Wellbutrin SR, Wellbutrin XL, there's Zyban, there's Aplenzin, and then now it's being combined with other medications and has other names. I actually think learning the history of the Wellbutrins is helpful for understanding why there's a bunch of different ones and the differences between them. So Wellbutrin was invented in 1969 by GlaxoSmithKline. The patent was granted in 1974, and then it was approved by the FDA in 1985 as Wellbutrin. And when it was first introduced, the recommended daily doses was 400 to 600 milligrams per day, and that people saw a significant incidence of seizures, so there was a withdrawal of the drug in 1986, and then it was reintroduced in 1989 with a lower max recommended dose of 450 milligrams a day, and we still see that today. So because of the half-life of the drug, the initial Wellbutrin needed to be taken 3 times a day. So in 1996, a sustained-release formulation called Wellbutrin SR was released, and this was intended to be taken 2 times a day compared to 3 times a day for the initial one. And then in 2003, the FDA approved another sustained release, and this one was called Wellbutrin XL, which is Wellbutrin extended release. I personally think that L is a poor choice of a letter to represent the word release. but I can't even pronounce the word, so who am I to judge? So the XL was intended for once daily dosing compared to the SR, which was 2 times a day, compared to the immediate release, which was 3 times per day. So the SR and the XL are now available as generic in the US and Canada. Moving forward, other marketings of the drug. So in 1997, it was approved as a smoking cessation aid, where it was called Zyban. In 2006, the Wellbutrin XL was approved as a treatment for seasonal affective disorder. Then in 2008, the FDA approved another formulation. So the initial Wellbutrin was Bupropion hydrochloride. So the FDA approved the new formulation, which was Bupropion hydrobromide salt. So instead of hydrochloride, it's hydrobromide. And there it was sold under the name of Aplenzin. A fun fact, in 2012, the company that made it, GlaxoSmithKline, pled guilty and paid a $3 billion fine for saying that Wellbutrin, for promoting the unapproved use of Wellbutrin for weight gain and sexual dysfunction. So I'm not promoting that. My bank account is actually currently at 0, and I overdrafted 2 days ago, so I wouldn't be able to pay that fine. Then in 2014, it was approved for weight management when it was combined with naltrexone, and then in 2022, it was approved with dextromethorphan as Auvelity for the treatment of MDD in adults, and it's, as I said before, considered relatively rapid onset of action. So to quickly capture the different formulations, Bupropion hydrochloride is the most commonly prescribed one. There's immediate release, which is taken multiple times a day. Then there's sustained release, which is taken 1 or 2 times a day. And then extended release, which is the XL tablets, and that's taken once a day. And the XL formulation is really the one that's used the most. And then Aplenzin is the hydrobromide formulation, so it's Bupropion hydrobromide. So this medication can also be taken 1 time per day. I should note that the milligram equivalents are not the same as the hydrochloride. The hydrobromide doesn't really offer any real clinical advantage. Theoretically, you should be able to use a higher dose because bromide salts have anticonvulsant properties. So theoretically, it reduces the risk of seizures, but this hasn't been proven. And then the 2 combination formulations is Contrave, Bupropion, and naltrexone, and that's approved for weight management in adults with obesity or overweight individuals with weight-related medical conditions, diabetes, hypertension, all that good stuff. And then Auvelity, which is the combination with dextromethorphan, and the fun thing there is that Buproprion inhibits the enzyme that dextromethorphan is metabolized by, so it'll increase the dextromethorphan. I don't really have any strong opinions on either of these drugs. They're new. I haven't used them. I know the Auvelity is really expensive. It costs like over $1,000 per month. But I have no opinions there. And then I think one of the enantiomers of Bupropion was being tested as a novel antidepressant. I also would expect in the future that you're going to see metabolites pop up as being tested. So it'll be like a Risperdal and Vega kind of situation. But as of right now, it's just the parent drug. So let's start with the mechanism of action of Wellbutrin. And I think people incorrectly think this is a psychopharmacology channel because the name is Psychofarm, but the farm clearly has an F in it. If I had to guess, I feel like I'll probably follow a similar trajectory to like Carl Jung. And as time progresses, I'll start going off the deep end and just start talking about God and astrology and alchemy. But for now, everyone's talking about biology and medication, so here we are. And when it comes to mechanism of action, one mistake I see a lot of early career psychiatrists and even like later career stupid people, which is a lot of people, they take the mechanism of action a little bit too seriously and think that like if there's a 1-to-1, you can actually like predict things from the mechanism of action. The truth is, you have to factor in how complex human beings are, and that everyone has a different neurochemistry. And also, we don't really actually know what the drugs do. We have like an incredibly simplified understanding of what's occurring. So I find the mechanisms are helpful for kind of creating a basic understanding of what the drug does and having a basic, like, there's a lot of things we can predict based off of the mechanism of actions, but the truth is we can't know everything. So we can't, it's not like you can say like, oh, this increases norepinephrine, so therefore this occurs, or this increases dopamine, so therefore this occurs. You really have to look at particular studies to see what kind of effects it has. So again, view these as like helpful for making big picture predictions, but not, it's never one-to-one. So Wellbutrin primarily acts as a norepinephrine dopamine reuptake inhibitor. And to understand reuptake inhibitors, why don't I show a quick clip for how it works with serotonin so you can understand how it works for dopamine or norepinephrine. So that should be here.
Take transport protein called SERT. And SERT is just short for serotonin transporter. I think of reuptake transporters as kind of like mini vacuums that suck up the neurotransmitters back into the cell. So when you block SERT, we know that serotonin lasts longer in the synapse and then can act longer on whatever neuron it's hitting, because the mini vacuums that suck the serotonin back are being clogged by the SSRI.
So unlike the SSRIs, Wellbutrin doesn't primarily act on serotonin. Bupropion works on NET and DAT, which is the two transporters responsible for the reuptake of norepinephrine and dopamine back into presynaptic neurons. So it's classified, there's different like names, but NDRI is a common one, norepinephrine dopamine reuptake inhibitor. And then just how like SERT is short for serotonin transporter, NET is short for norepinephrine transporter, and then DAT is short for dopamine transporter, DA being dopamine. And the inhibition of these transporters results in an increased concentration of the neurotransmitters in the synaptic cleft. So you have an increase in dopamine and norepinephrine more generally. And then the other major receptor that it acts on, so it acts on nicotinic acetylcholine receptor, and it acts as an antagonist there. So nicotinic acetylcholine receptor antagonist. So it's a non-competitive antagonist at these receptors. So that means that it binds to them, but it doesn't activate them. So the antagonism will decrease the rewarding effects of nicotine, and that's why you see it helpful as a smoking cessation aid. And then usually when we look at the binding profiles of the other drugs, you'll see they'll have small effects on a bunch of different other receptors, but you don't really see that with Wellbutrin. So you don't really see any kind of meaningful activity at a bunch of receptor types. So you don't see any kind of serotonergic, histamine, or muscarinic acetylcholine receptors. Aside from the transporters, you don't really see it acting on other dopamine or norepinephrine receptors. And there are vague, you will see vague things like it has modulation of certain receptors, but you don't really see it for the vast majority of neurotransmitter receptors. And some the neuroimaging studies, so you can look at like PET scans to see what percentage of the receptors are occupied. So PET scan showed that it occupied like 20% of DAT receptors at 300 milligrams per day. I think a good comparison would be like looking at Ritalin, which is another NDRI, and that occupies more than 50% of the DAT receptors. So it's a smaller percentage. And then in a PET scan study where they gave a 150 milligram dose of bupropion, there was no measurable dopamine release. So dopamine release is different than blocking DAT. So there's no like actual release of the dopamine at that dose of Wellbutrin. And unfortunately, I couldn't really find any data on net percentage blockade. But just in general, the clinical effects of bupropion are more consistent with noradrenergic activity than with dopaminergic activity. So it's possible that NET plays a bigger role than DAT, but who actually knows? So then talking about side effects, let's just pull up the prescription label. So the two big ones that you need to look out for are just GI side effects. So you see a higher percentage of dry mouth, and then nausea, constipation, and diarrhea. And of course, it's important to compare it to placebo when considering whether or not it actually causes side effects. The other big one that's worth mentioning is headaches. So there's a pretty substantial percentage of people who get headaches. I think it's the highest incidence across all the second generation antidepressants aside from Effexor. And then we also see a higher incidence of insomnia, and then also higher incidence of tremor. So the most common ones in general, to recap: dry mouth, nausea, constipation, insomnia, tremor, and then also you see a little bit of increased anxiety maybe, and excessive sweating. And then the less common but more serious side effects. The first one is seizures, and I'll talk about that in more detail later in the video. I kind of just want to keep the side effects short during this period. The other ones you do see are SJS, Stevens-Johnson syndrome, and anaphylactoid reactions have been reported. It is a possibility for a switch to hypomania or mania, not as much as with the other SSRIs, and I'll talk about that again a little bit more later. You do see raises in blood pressure, and again, I'll talk about it a little bit more later. And the other one is there is an FDA black box warning for increased risk of suicidal behavior and thoughts in people younger than 25. So this black box warning is on all antidepressants, which in my opinion is a little silly because it doesn't matter the mechanism of action, and it isn't necessarily true. So it's based on a statistical analysis that the FDA did that found a twofold increase in suicidal thoughts and behaviors in kids and adolescents, and a 1.5-fold increase in the 24 age group. So in the analysis, the FDA combined the results of 295 trials and 11 antidepressants. So it's grouping all the antidepressants together, which doesn't make a ton of sense when you're looking at like specific medications, because it's possible that certain medications caused a significant increase and other ones had a decrease or didn't have an increase. So it's almost a little silly to group them all together. And when considered in isolation, Bupropion did not separate statistically significantly from placebo with regards to suicidality. But I'm not an expert on this, and don't quote me on this, and don't hold me liable. Everything I say here is a lie. Don't trust it. Don't sue me. And then the last side effect worth mentioning is discontinuation syndrome, which refers to if you abruptly stop or reduce the dosage of the medication. It's less commonly associated with Bupropion compared to like the SSRIs, but it does occur. You just kind of feel generally crummy and have mood changes and irritability. Also the fact that you're coming off the medication, you don't know if it's recurrent of symptoms, but yeah, typically whenever you go down on medication or stop it, you're going to feel crummy, but it's not as intense as the SSRIs. So it's typically milder symptoms and a shorter duration than the classic antidepressants. And I guess it's relevant here, so let's talk a little bit about the metabolites of Wellbutrin. So Bupropion is metabolized through 2B6. B as in boy. With a lot of psych drugs, you usually see 2D6. So metabolized through 2B6. And Wellbutrin does have active metabolites. So the three big metabolites, and there's really no reason to learn these things, but I'll tell you them anyway. It's hydroxybupropion, 3-O-hydrobupropion, and then erythrobupropion. And again, it's not that important, but hydroxybupropion is the major metabolite, and it has a lot of the same NDRI activity, the NET and DAT blockade, and probably represents a large proportion of the drug's therapeutic effect. And then you should have a vague overview in your head of the important drug-drug interactions with Wellbutrin. So there's really like three main types of drug-drug interactions you should be thinking of. There's the pharmacokinetic drug-drug interaction. So there you're thinking about the 2D6 inhibition. Then there's the pharmacodynamic drug-drug interactions. So there you're going to be thinking about too high levels of catecholamines. And then the third type is any drug that's going to additionally decrease the seizure threshold. So in a little bit more detail, the pharmacokinetic interactions, we know Wellbutrin inhibits CYP2D6. So any sort of drug that is metabolized through 2D6 is going to be affected if you're taking Wellbutrin. So this is not an exhaustive list of all the 2D6, but just a few to get your mind thinking. It's going to interfere with the analgesic activities of codeine. It's going to increase the level of some beta blockers. Probably relevant because it's also connected to ADHD. It's going to affect the metabolism of atomoxetine. So it increases systemic exposure of atomoxetine about 5-fold. Then also vortioxetine has in their prescription label or the manufacturer label that you shouldn't be using more than 10 milligrams a day if you're using Wellbutrin. Higher levels of the vortioxetine are associated with more side effects. It's unclear if this is necessary, but you should be thinking about the fact if you're using Wellbutrin, you're going to delay vortioxetine metabolism and you're going to have higher levels in your blood. And then again, any drug that is metabolized through 2D6, which is a lot of the psych drugs, so you're going to see higher levels of Prozac, Paxil, Effexor, some TCAs. Just important things to keep in mind. In regards to the pharmacodynamic interactions you should be thinking about, anything that's going to significantly increase norepinephrine, so you should really use it with caution with the MAOIs. There's going to be an increased risk of a hypertensive reaction because MAOIs break down the norepinephrine, so you can get a dangerous increase in catecholamines, and then you're at risk of possibly causing a hypertensive crisis. And then again, you should use with caution that with any drug that's going to increase the seizure risk. Thinking for psych drugs, TCAs, lithium, phenothiazines, some of the antipsychotics. If you're using in conjunction with a lot of drugs that decrease the seizure risk, you can run into problems. So again, that's not an exhaustive list of the drug-drug interactions, but I think it's helpful to think in your head. You have the inhibition of 2D6, so any sort of drug that is effective there. You don't want to be careful with any sort of major increase in catecholamines, and then any sort of drug that is also decreasing the seizure threshold.